If you're trying to conceive and feeling overwhelmed with fertility advice, then this podcast is for you. Welcome to Don't Tell Me to Relax, your fertility podcast and antidote to unhelpful fertility information. I'm Hannah, a fertility acupuncturist, teacher and campaigner for better fertility education. This podcast aims to empower and inform you about your menstrual cycle and fertility. It's basically all that information you didn't get in sex ed at school, with the aim of improving your understanding of your reproductive health and optimizing your fertility. Hello everybody and welcome to this episode. I am very excited today because I am joined by a real life GP, Amanda, who has come to talk to us as the follow-up because we've done a part one of fertility testing, which was myself and Katie. And now a while ago, I was on Amanda's podcast and I said, can you come on and talk to us? Because it's so great to hear about fertility testing and to hear about things from a GP's perspective. So Amanda, thank you so much for joining me. Would you like to introduce yourself and tell us a little bit about what you do?
Yeah, absolutely. Thank you so much for having me. I'm really excited for today's conversation. It's an important one. And yes, the episode that we recorded on my podcast is coming out this weekend. So I'm very excited. But my name is Amanda. I am a medical doctor. So I am a GP, but I'm also specializing in lifestyle medicine as well, which is all about like holistic care and looking after all the parts of you, not just treating you with medicines and surgeries. And yes, what I do is everything basically. As a general practitioner, I see people from birth right till end of life, and everything that comes in between. And a massive part of that is growing your family and dealing with the journey of that. And so that's where I can help as a GP. And yeah, that's me. I've done lots of different rotations. So although I'm now in the primary care or the general practice community kind of medicine, I've also done a lot of secondary care. So working in hospitals, I've worked on obstetrics and gynecology. I've gone to fertility clinics, all things to kind of aid my own learning. And that's how I help my patients now.
Amazing. And so what's it like? Because we hear a lot at the moment around doctors, GPs, and the pressure that you're under following, I guess the pressure has always been there, but it seems like it's just got worse and worse since COVID. How is it for you at the moment in work?
So I've got a special situation now because I completely burnt out. The pressure in general practice is very intense at the moment. And in 2020, I was actually on maternity leave with my first child when the pandemic hit. I returned to work in September and it was a completely different world. And I really started to just take on, there was just so much work that we were doing. And then in 2021, I fell pregnant with my second child, still in this whole COVID type of world and all the pressures that were there. And I just couldn't manage the workload, the work pattern, the practice that I was in. It was just all too much. And so I took early maternity leave and I spent the last year and a bit retraining and going into things that I'm more passionate about. I quit the practice that I was working in during my maternity leave. And so now I still work in general practice, but my hours are very different. My boundaries are very different. And I've also got my own, away from the NHS work that I do as well. And so for me, my day-to-day work, I found an amazing practice. It is much more manageable, but I had to do something unconventional because it was burning me out. Yeah.
I can only imagine what it must have been like. I would love to hear when you were training, to what extent did you cover fertility and sort of menstrual cycles, women's health, and I guess not only that, but what I'm really interested to know, and it's great because you have trained and you've got a real great understanding of holistic practice as not just sort of the sort of Western medicine approach as you're taught it at university. But I would love to hear what it's like at university when you're training to be a doctor in terms of what level of information do you get around fertility, menstrual cycles, women's health? Is it very medical, or do you look at the wider picture in terms of the other things that impact women's health?
No, so in medical school, especially when I went, it was very disease focused. And so we looked at the diseases, the symptom patterns, how to diagnose them, the management options. That was very much what you did. And then because I went into general practice, all of my training has been quite general. So when you leave university, you go into foundation training where you do different specialties, but you're working really like I don't know what the word is, like an intern. You're the one running around after the consultants, writing the notes, ordering the tests, and you're very much admin, like you're an admin doctor at that time. And
Yeah.
then you go into training, specialty training. And because I chose another general subject, general practice, it was again jumping around to different specialties. And so you'll see with general practitioners, you'll get although we all have the baseline knowledge, we all get examined, we all have to know a lot about obstetrics and gynecology. We need to know the conditions, how to spot the different things. But for you to really take a deep dive into anything, you've got to do that out of your own choice. And there are some people, we only get 3 rotations in hospital medicine before you go to general practice. And so some people won't even do obstetrics and gynecology. They won't do women's health. And so it's really like textbook learning and then what you learn from GP. And so, yes, it's not really a holistic approach that you get depending on, if you get a specialty in a hospital that is very holistic, or you end up being linked with a consultant and you can go to their clinics and they deal with things in a different way, then you might get exposed to it. Other than that, it's really being intentional about what you want to learn. And you can do that. So I used to request to go to different clinics and fertility clinics. I used to do additional like learning online and going into like different communities and finding out about those things. But that's because of my interest, and because as a female GP you see a lot of women, and so it was also important that I knew that too. But additional courses, you've got to do that all yourself. It's not part of the basic training.
That's so interesting, isn't it? Because I guess there is this history of, I mean, I'm just thinking menstrual cycles here. And funny, just because I've been talking about it a lot recently, of this idea that if you've got a problem, let's say you're a teenager, and I know Davina has obviously just done her huge documentary on this. Let's
Yes.
say you're a teenager, you go to the GP and you've got problematic periods. So let's say they're painful or they're very heavy. I guess from your training perspective, and forgive me, correct me if I'm wrong here, your solution is contraception or painkillers because that's your learning. Am I right in that?
Yes. Because the issue is women's health has been really under researched,
Yeah.
and we live in a patriarchal society, and medicine was a very male dominated field, and the research that goes into it was very much dictated by the leaders of society at the time. And so because everything we do needs to be evidence based, and there's so little evidence for a lot of women's health issues because there's not been enough studies, we are then working off where the evidence is. And so the evidence is always in contraception or painkillers. But there has been a shift, and we're
Yeah.
learning a lot more now, but it does also depend on the doctor that you see sometimes.
Yeah. It's interesting, isn't it? Because obviously obviously I'm really privileged in that as private practitioners, when somebody comes to us with an issue, we have an hour and a half to sit with that person. So if somebody came in to see me with period pain, then I've got the opportunity to spend an hour with that person looking at all the different aspects of their life that might be impacting their period pain. So what they're eating, how they're sleeping, what their stress levels are, how much exercise they're doing, if they're drinking water, all the kind of foundational parts of good health that support good menstrual cycles and, as an extension of that, good fertility. So I guess it's also about the understanding and the learning, but also about the time that you have.
Yes, the time, that's the biggest thing that I struggled with, because I'm someone that likes to delve deep into things, ask questions, and come up with shared management plans, and make things very patient centered. But we get 10 minutes.
Yeah.
And like I said, I have changed my schedule now and the way that I work. So I've fought for it, and now I get 15 minutes. But
Right.
that's really it. To get more than that is very unusual. Sometimes you request to have double appointments, and there just isn't the facilities to do that. And so the time pressures, there's so much we can do in that time, don't get me wrong. And in
Yeah.
GP, you don't just have to have one appointment, we can do follow-ups, but the time pressures are a significant part of it.
Yeah, it's a problem, isn't it? And I don't see it changing anytime soon, given the way that funding is and NHS is. It's a big problem, I think.
Yeah.
So in terms of fertility, how
hmm
much do you see in your clinic? Like what kind of issues bring people into your clinic from a fertility perspective?
So there's a range. The one that's so sometimes we get people that are wanting to have children, and this is the rarest one, and this is the one that I wish I saw more of. Someone that knows that they want to have children, and so they want to discuss their options, what do they need to do to give themselves the best chance, and asking advice before they start the journey. I love those appointments, but those are few and far between.
Mm,
After that, it's really people often coming after. The most common is that someone has been trying for years, and they just hadn't gone to seek any further help. They have been in this relationship, maybe it's been 5 years, and they just kept trying. Or there's people that weren't necessarily trying, but they were having unprotected regular sex, and it's been a few years now. They're like, I should have fallen pregnant. I know that I wasn't trying, but what's going on?
mm,
And so we get those where it's been several years that they've been trying for. And then we do have proactive people who've come up to often like the 3 to 9 month mark. And they're like, what's going on here?
mm.
I've not gotten pregnant. I'm trying. I'm doing all these things. Help me. And then we also have people who are having, they think they may have problems because they have irregular periods or they're not having many periods. And they just want answers from that point of view.
And from your perspective, I mean, sort of from a guideline perspective, I think it's like 36, 30, under 36, it's the sort of general recommendation is to wait a year of having regular unprotected sex. And over 36, it's 6 months. Is that right?
Yes.
And
Yeah.
then if there's any gynecological issue, it's 6 months or sooner.
So if you have a known problem that
Yeah,
may affect your fertility, then there isn't a set time frame for when you should get investigations.
right. Yeah,
Under the NHS, everybody should has the right to be referred to an NHS clinic for investigations. And so that's something that some people don't realize. They think of, oh, IVF, there's all these caps on it. I'm not going to be able to get, any kind of help with this because I don't meet the requirements for IVF. But although you don't meet the requirements for IVF per se, you do have the right to have investigations under the NHS and get answers from that point of view. Now, yes, if you have nothing to suggest that you'd have a problem, you have regular periods, you've never had any sexually transmitted infections, you've never had like pelvic inflammatory disease, you have never had like a pelvic or abdominal surgery, you've not had any kind of like cancers or cancer treatment, if there's nothing to suggest that you would have a problem and you have regular periods and you're under the age of 36, then try for a year. And the
okay.
majority of people in that situation would be absolutely fine. And it's not just I just mentioned problems with the women, but also problem with your male partner as well.
Mm,
So if you are having if males have had previous STIs, any kind of genital issues, abnormalities there, if they've had any genital surgery beforehand, and if they've had any cancer treatments in the past, then also, those are reasons that you don't wait 6 months. You can say that I want to have a baby, I'm just trying, and it's been a month, or you're just about to start trying, and you can get a referral for further investigations.
yeah. And that's really helpful. Thank you. And with that, with it, taking your kind of GP hat off,
Mm-hmm.
what do you think? Because people ask us all the time, and this is just my opinion, and my opinion is that if you know that you're going to try and have a child,
Mm-hmm.
whether you've got any problems or not, I would say, especially in terms of male factor, I would say
Mm-hmm.
having a test done sooner, so
Mm-hmm.
before a year. I know there's NHS guidelines and they're there for a reason,
Mm-hmm.
but in my opinion, if I had enough money to go privately, I would say as soon as you start trying, there is some value in investigating, doing basic tests. So doing a sperm test, maybe doing a basic hormone panel, maybe checking thyroid. Do you agree, or do you think actually it's best to wait a year and follow the NHS guidelines? I'm not
Mm-hmm.
asking you this from your
Okay.
personal opinion.
Yes, no, I agree. So in terms of sperm count and having that investigation, I hadn't considered that one. But what I will say is that for myself,
Mm.
I was, when I wanted to have a child, I was 26 and no issues, regular periods, no reason to think anything was wrong. I went to my GP and I got a whole host of MOT bloods done.
Right.
I got checked for my thyroid function, my full blood count. I wanted to know my iron levels. I wanted to know my vitamin D status, my folic acid status. And a lot of these weren't because I was worried about falling pregnant or not being able to. It's because I wanted to optimize the health of my pregnancy.
Mm.
But I also did check like that I'm ovulating properly. Even though I was having bleeds every month, I still wanted that panel done. And because these bloods we don't just do for fertility. You've got, polycystic ovarian syndrome, or you're having irregular periods, or whatever. You can request these blood tests, and there isn't really a reason to say no to it. So I had all of that done
Mm.
before I started, and then at that point I started to just like before I started trying, I made sure that I wasn't having excess amounts of alcohol, and I checked my weight and I did all those things. I also did the blood test too,
Yeah.
because it wasn't for fear of fertility problems, but I wanted to get pregnant and I wanted to know what my status was. And I just feel like there's a lot of empowerment in education, and
Yeah.
then you can move forward from that. If you are in that 20s, early 30s range, I wouldn't, if you are having regular periods and there's no other reason to be concerned, I would go and get like a panel of bloods done. um you can also do a sperm check. That's also available on the NHS. Your GP can request it for you. You don't have to have a referral to a fertility clinic to have that done. And then
Yeah.
but I wouldn't start stepping up investigations after that point until you've tried for a little while.
Yeah, and I totally agree, and it's so good to hear you say that, because I think so many people are fearful of wasting time, wasting money. Sort of it's too soon to ask. But I'm a bit like, why wait? Because it's about being in the best possible health you can be. Because exactly like you say, it's not just about getting pregnant; it's about having a healthy pregnancy and a
Mm-hmm.
healthy birth. And we know that, like you say, vitamin D, iron levels, all these things are really important.
Mm-hmm.
And I also think, in terms of the male testing, that in some ways, I know you can't always tell, but if you've got a good regular cycle, if you've never had any period problems, if it comes regularly, you can see cervical mucus, you don't get
Mm-hmm.
pain, then you've got a good basic understanding that your
Yeah.
hormones are probably working okay.
Mm-hmm.
But when it comes to male health, I can't tell you how many times I sit in clinic and people say he's really healthy, he exercises, he doesn't
Mm-hmm.
drink, he doesn't smoke, and then they do a sperm analysis and something comes up, and
Yeah.
it could be a lifestyle factor, it could be a varicocele that's never been identified, it could be an infection that they didn't know that they
Mm-hmm.
had. And I always feel, rather than spend a year trying, and it might not be optimal, why not
Yeah.
investigate that as soon as possible?
Mm-hmm.
Because there might not be any obvious signs of male factor fertility problems.
Yeah.
Whereas I don't know whether I'm just thinking this out loud, but I think, like, for female problems, it's a bit more noticeable, because you might,
Yeah.
not for every case, but a
Mm-hmm.
lot of the time you might be able to spot, clotty, heavy periods, painful periods, or lots of PMS, lots of breast tenderness. And you might think, okay, maybe there is a bit of a hormonal imbalance. But with a
Mm-hmm.
man, I feel like it might be harder.
No, you are absolutely right. And thinking of it now, at the time, I didn't think to do a sperm check for my husband,
Mm,
but thinking about it, and I guess because I had that, the guidelines in the back of my head, as I just want to optimize myself, and I was thinking more about the pregnancy, but
yeah,
absolutely getting a sperm check done. That
yeah,
it's not an invasive procedure. It's not a procedure. They just do their sample and send it off to the lab in a timely manner. And so yeah, it's definitely a good thing to do. Especially because a lot of sexually transmitted infections are completely asymptomatic for a lot of people.
yeah,
And if they have had, other partners in the past, it's an important thing to check, isn't it?
yeah,
Sometimes men can have blockages, where so you get semen from your prostate, so that's outside of the testes, just below your bladder, but the sperm come from your testes, and so some men can be ejaculating completely fine and having semen, but then they test it and there's no sperm in there because there's a
mm,
blockage somewhere, and all the
yeah,
sperm is sitting in the testes. And if you find that out right at the start, so much can be done, and it's a very simple test to do.
yeah. I know that's the thing, is it is a really straightforward, simple test, isn't it? It's
Hmm.
not. like, we have smears, we have, hycosis, we have all
Yes.
kinds of, pretty invasive tests. Let's not beat around the bush. And I
Mhm.
know, like, it's not for lots of people, nobody really wants to go and do a sperm test, but it's quite straightforward and it can give you so much information.
Yeah.
It's a good idea. So lots of people that we work with are often told by their GPs, rightly so, keep trying and come back in a year.
Mhm.
So what can people do to, when they've been told that, if they're concerned and they feel like, hang on a minute, but I really want these tests, but my GP says I don't qualify for them. What's
Yeah.
your advice in that situation?
So it's depending what they're saying you don't qualify for. If they're saying that you don't qualify for some basic blood tests, I would just challenge that,
Yeah.
because what are the criteria? What are the guidelines? I would say, well, could you show me where the guidelines are for me to get a blood test done to show what my follicle stimulating hormone is, and to show me what my luteinizing hormone is, and check my testosterone levels? Because like, what are the guidelines for having that done? I'm trying to have a baby, I'm concerned, so I'd like to have the blood test. And they won't be able to show you a guideline that says they can't have the basic blood test, because there isn't one there. They can have it. So I would just challenge it and say, I just want the blood test.
Yeah.
And I know there's a lot of GPs that feel like gatekeepers to investigations, but
Yeah.
we don't need to be for this kind of thing. It's not like if somebody was coming to me and the results of it may lead to inappropriate tests. So, for example, there are other blood tests, such as like the prostate blood test. And if like a 20-year-old comes to me, 20-year-old man wants to have his prostate blood test done, and there's no symptoms, no reason for it, although I could do the blood test, I would advise against it, because you can get like a false result, which can lead to a prostate biopsy, which can lead to an infection. For what reason? Why are we doing it? But this is a very good reason. And so I would push back on it. If you're struggling with that GP, you can always ask for another GP in the practice to speak to them. You can always also write to the practice manager as well and just say, I just want to have this blood test done. I don't see why I'm not being allowed it. And I think, to be honest, if you question the GP first in the first instance and ask you the guidelines, I doubt that there would be much more pushback from that point of view. Especially if you say, you just want to optimize your chances of getting pregnant, you want to optimize your pregnancy like health. I don't think there should be an issue. But if you're getting additional pushback and you want to have additional investigations, say you have the blood test done and they come back as normal, but you want something more to happen because you're not comfortable in just waiting a year, and for whatever reasons they may be, then you can also get these investigations done privately. Investigations usually cost less than £1,000 to get all the things done: semen analysis, a check of your fallopian tubes that they're patent. It's usually less than £1,000 to have done. And so that is an option for you. And if that comes back with results, you can then sometimes get an easier NHS referral because now a problem's been found. Yeah, so that's an option there too. I was just going to say, with the tests, say that you did want anything ongoing, or your GP was kind of saying no, you can also say to them, can you just write me a referral? Just write me a referral to the NHS clinic. If they say that, if they reject it, then fine. But sometimes they may not, because you may meet the criteria. And so just asking them just to have a go and let someone else reject it, that's also an option too.
So when you say referral, you mean like to an IVF, to like a fertility clinic?
Yes. Yeah.
Okay.
So say you want to have more than, so in GP, we have very basic tests. We can just check if you're ovulating. And sometimes the tests, they need to be done at a certain time in your cycle. And so if you miss that day or anything slightly off, then the blood test can sometimes be inconclusive. But to get any further testing to know what your egg reserve is, then we can't do that under the NHS. I mean, we can't do that as GPs. If you want that further testing and you don't have the finances to do it, and you're not quite meeting the criteria, or your GP said, oh, but your partner has a child, so you're not going to get IVF, can you please just refer me? And then let the fertility clinic make the decision if I can have them or not.
Oh, that's really, that's a good top tip.
Yes.
And what about in terms of, I think the thing that I see lots of patients struggle with is getting a transvaginal scan to check the environment, so it might be that they've got spotting before their period comes, or they've got late ovulation, or, they've got pain. And so a transvaginal scan, is that because there's always this confusion about whether you need to see a gynecologist or whether you need to see a fertility doctor. So what would you in that situation, what do you advise? Because I presume a transvaginal scan is a referral.
No, so transvaginal scan, I request those all the time as a GP.
Okay.
But we do have referral criteria for it, and so sometimes they can get rejected, and so your GP needs to know how to word things correctly,
Right.
and sometimes to have a look at what the requirements are for that trust, that NHS like system area, to be accepted. So for example, if I just wrote down someone's having heavy periods for ultrasound scan, that will get rejected, and they say, have you not tried any kind of treatment before sending them? And so then if I wrote instead, this person's been having heavy periods for the last 12 months, she has tried non-steroidal anti-inflammatories for it, or she has been on contraception for this long and it hasn't worked, I'd now like a scan, that would get through. And so your
Okay.
GP has to know also how to word it. But absolutely, we do ultrasound scans all the time.
Yeah.
And so that's something that can be arranged from us. And if something is found there, sometimes you might find a problem that doesn't need to be, you may not meet the criteria for fertility treatment,
Yeah.
but there are some things that you can have done that help your fertility.
Yeah.
So say, for example, you haven't met the fertility requirement because you've had a child before, or your husband, your partner has a child, so you can't have IVF. You can still have investigations, but say you find out that you're having heavy periods and you want to be investigated for endometriosis and you want treatment for that. It's technically something that helps your fertility, but we can refer you to a gynecology clinic instead and have you as treated for endometriosis and not say it's for fertility. And
Right.
that can aid you there. You have fibroids, we can refer you to a gynecologist to have your fibroids looked at or have them removed or have, whatever treatment is needed from that point of view, but not being referred through to a fertility clinic, but you're still having things that aid your fertility.
Yeah, and I presume that must count for polycystic ovaries as well, in terms of, because that's a gynecological issue, a standalone gynecological issue that does have an impact on fertility, but it is also a gynae issue.
Yes.
Yeah.
And so if you have polycystic ovarian syndrome and you want to, first of all, if it's diagnosed, it depends on how comfortable your GP is. There is a medication called metformin, which is supposed to help with ovulation in people with PCOS, and that can be prescribed by your GP. We prescribe metformin all the time, so that's an option. If you want your polycystic ovaries looked at, you can be referred to a gynecologist separate completely from fertility issues. And so, there's still options there. There is also the option as well, say you're not able to get through to a fertility clinic in the NHS, and maybe you don't have the funds to go down the whole route privately. You can do parts of it privately. So as I mentioned before, you can go to a private clinic and get all the investigations done, less than £1,000. And they may say to you, oh, okay, you're not ovulating regularly enough, or you're not ovulating at all. There's a medication that you can use called Clomid or clomiphene. If a registered consultant gynecologist has written that down, that letter can be sent to your GP, and your GP can prescribe that for you for 6 months, and then can sometimes get you referred in. If you still don't meet the requirements for fertility, you might have to go back privately, but you can get Clomid or clomiphene prescribed by your NHS GP, providing that it's been recommended by a gynecologist, whether it's in the NHS or not.
Interesting. So there are ways of kind of circumnavigating the system. Yeah. What about this has just come to my head. What about progesterone? Because we get so many people asking or talking about progesterone, because we do see a lot of people with like problematic luteal phases of their menstrual cycle. So it might be post contraception, or just a sort of their cycles. It is actually quite often post contraception that their cycles, that second half, has just never been sufficient enough. So it's often maybe 10 days. They only have 10 days after ovulation to when their period starts, or they might have spotting for many days before their period starts. And lots of people sort of ask about how can they support their luteal phase? They might not want to go for IVF. They might not qualify for IVF. And so people often ask us about progesterone, and it's a difficult thing to get prescribed from a private fertility clinic. I presume there's no way around it from an NHS point of view.
Yeah, also again, it's the kind of thing where it wouldn't be something that I, in my role as a GP, would be comfortable in prescribing, just because I don't. It's important that we don't cause harm, and so
Yeah,
if you don't know enough about it because it's not your area of specialty, you
yeah.
need advice on it. But say you do see a private clinic and they have recommended that you should be on progesterone, they give a clear plan of it. Um, Depending on what is being asked and how much monitoring is needed,
Mm.
sometimes that can be then brought to your GP and we can manage
Okay.
that.
Yeah.
But it really depends on what is being asked. If there is a lot of blood tests that need to be done with it, or a lot of like titrating or changing the doses and working with it that way, a lot of GPs won't be comfortable doing that
Yeah.
because there's not enough
Yeah.
information there. But say there's a set dose or something, there's very clear instructions from the consultant, you've had the test and we can see it all clearly documented. Sometimes there can be additional help there. But
Yeah.
it is that progesterone for managing that is often more a gynecology
Yeah.
specialist field.
Yeah. And thyroid is something that comes up that's quite controversial quite a lot of the
Mm-hmm.
time. So, the idea of the NHS sort of breadth of the range, and then the range that's there for fertility. So a lot of private fertility clinics look for the thyroid, for the TSH value to be under 2.5, and yet the kind of NHS guidelines I think of for like to 4.2 or something. So is that something that you come across? Because it's something that we come across a lot.
Yes, it's not something that I come across like regularly.
Mm,
I've had instances of it, but it's not a regular issue.
mm,
Um, Now, often when that happens, we can test you for your like, your actual hormone levels, your T3, your T4. We can test you for thyroid antibodies, and we can also get support from an endocrinologist if there's any issues there. But it's not something I've had a massive issue with. If they have gone to a fertility clinic and their ranges are different and it's been documented quite clearly, and your consultant has suggested that you do need to go on to some thyroxine or you need to have some further treatment, then often we don't usually have a problem with it if
mm.
it's been documented clearly and there's a registered specialist that have seen you and they've said clearly what medications you need and how it needs to be monitored. In those cases, some GPs may wish to refer you to an endocrinologist as well, a hormone doctor. But those options, they're there.
Yeah. Okay, that's so good to hear. Thank you. So in terms of like just to finish off, like your top tips.
Mm-hmm.
So if you are somebody who's ringing up, you want to have some investigations done, what would be your
Mm-hmm.
top tips for seeing your GP and getting the right test done?
So my top thing would be to find out what are the criteria in your area. So knowing that gives you an idea of how much time you have and whether there are any options to you in terms of treatments. Once you know that, I think all of us should say, go to your GP and say, I'm wanting to get pregnant. Can you tell me, I want to get some blood tests done. I want to find out a whole panel of my health. Pregnant or not, this should be allowed. So I want you to tell me everything. I want to have my fertility bloods done. So that's the first thing that I would request for. And now that you've said, I'd also get a sperm count done too from the GP. I would then say, once you've optimized everything you can, you're having regular sex, you're looking at your weight, you're looking at how much your alcohol you're having, you're stopping smoking, and all those things. You need to have a look at what your risk factors are yourself. Have you had an STI in the past? Have you had any abdominal surgery? Because those things will bump you up the list to get referred earlier. And then the third thing is to use the private healthcare effectively. A lot of the time we think that it's too expensive, I can't do any of it, but sometimes you can do parts of it. So
Mm,
insisting on having a referral to a fertility clinic, knowing that you won't be able to get IVF, but you can get all your investigations done under the NHS. And then when you're going to the private clinic, you can take all of that with you. Or knowing that, I'm not going to get the fertility investigations done for another 6 months. I'll go to a private clinic. I get the investigations done quickly. I can afford that. It's under £1,000. I'll bring that to my GP. I'll ask them to refer me to a fertility clinic now. But in the meantime, I'll get my clomiphene or my Clomid and I'll use that for the next 6 months whilst I'm waiting. And so using the private healthcare system to your advantage and knowing that the big cost of IVF, you can split it into smaller chunks and work
mm.
with your doctor in that way.
Amazing. That's so helpful. So helpful. And just before we go, just because I'm
Mhm.
always interested, what do you think about the at-home blood tests? Because they seem to have exploded
Mhm.
on the market now in terms of, Medichecks, Let's Get Checked,
Yeah.
Fertility. There's a whole new kind of industry out there. Well,
Mhm.
it's not new, but it just seems to have got bigger. What do you think about that?
I think they're great, to be honest.
Yeah.
I think they're really, really good. I think it aids everybody. It helps you as the individual, trying to figure out what's going on with yourself, but it also aids us as well as your doctor. A lot of the time we don't want to not help, but there are restrictions that we have. But if you
Mm,
come to us with an evident problem that's there, suddenly that referral is so much easier to write and to advocate for you to get the tests and the treatment that you need. And so I think it's a great thing to invest into. It's like I say, knowledge is power. So
yeah.
get as much education as you need. I guess the only thing that's a caveat there is some of them, they give you results, but they don't really have much follow up
Yeah.
necessarily with it and
Yeah.
explanation of what they all mean. And so for myself, I don't request tests that I can't explain the outcomes of. And
Yeah.
so some of those, we've seen some tests being done and then they're just like, and that's weird, go and see your doctor. And he's
Yeah.
like, what do we do with this? And so that can be the limitation sometimes. And also make sure you time the test correctly. And because when you're doing hormone tests, if you haven't got it at the right point in your cycle, they can just mean absolutely nothing.
Yeah.
And so there's some limitations, but overall, I think they're a really good thing. Share
Yeah.
them with your doctor, your results.
Yeah, I think that I mean we use them a lot in clinic, and I think
Mhm.
they are. Certainly from when I started in practice, and we used to always just have to refer people back to their GP.
Mhm.
It has been an absolute game changer that people can do this stuff themselves. They can do it at home, and then that's exactly what we say. Then you can go to your GP and say, "Look, this has come up for me, and can you refer
Mhm.
me?" And people do find it really helps them, get heard. I think.
Yes, yeah, it does. Because sometimes when you're going, you're just saying, "Oh, I don't know, I've not gotten pregnant. It's been 4 months." Like a lot of us as doctors, we're seeing so many patients,
Yeah,
and you're like, you have regular periods. It's been 4 months. Okay, keep trying. Come back to
yeah,
me later.
yeah,
Like there's no problems here. But you come, you say, "I've been trying 4 months. I did this blood test, and look, it doesn't look like I'm ovulating, or
yeah,
my thyroid's out of whack, or this has happened." It's like, okay,
yeah.
right, I can do something with this information.
Super. Thank you, Dr. Amanda. Thank you so
No
much. It's so
problem.
good to have you on the podcast. I really, really appreciate it. And I know that this podcast is going to be super, super practical and helpful. So I really want to say thank you for your time. We really appreciate it. And I will put all your details, as always, on the show notes. And thank you
Thank
very
you.
much.
Yeah, brilliant. Thank you for having me.
All right. See you now.
Yeah. Bye.
If you've enjoyed listening to this and want to find out more, then come and join my free community in Facebook. We have loads of resources. You can catch up on all our previous webinars and be the first to know about forthcoming events. To sign up, just follow the link in the show notes. And if you'd like to work one-to-one with myself or one of the team, then please see our website, hannahperm.com, where you can book in directly or organise a discovery call to find out how we can support your fertility and your reproductive health.